As Len said, I work at Katie, and I do all the knowledge exchange work around sort of the biological aspects of HIV prevention. And I'm also involved in a few research studies that are being led by Dr. Dial Tan here out of St. Michael's Hospital around the implementation of pre-exposure prophylaxis. So today I'm just going to cover the basics of PrEP. I'll review the science on what we know about how well it works and how safe it is. Then I'll talk a little bit about what's happened to move PrEP into practice in Canada and elsewhere. And then I think there's going to be time for questions after both Isaac and I speak. So just the basics. So PrEP, of course, refers to the ongoing use of antiretrovirals by HIV-negative individuals starting before an exposure and continuing afterwards. So this is different than post-exposure prophylaxis, which only involves the use of antiretrovirals for a month. And it's only meant to protect from a single exposure to HIV. While on the other hand, pre-exposure prophylaxis has the potential to reduce the risk from multiple exposures to HIV. This is a potential HIV prevention option during periods where a person is at high risk of HIV infection. All the guidelines around PrEP are recommending it be offered for people who are at high risk, and they define high risk in different ways. And this is because PrEP is expensive and it also does carry some risks. And right now, PrEP is sort of synonymous with the daily use of a pill containing tenofovir and emtricitabine, which is branded as Truvada. But it's not just about taking a pill a day. It also involves regular visits with a service provider, generally every 3 months. These visits are meant to test for HIV and STIs. So if someone's taking PrEP and they become infected with HIV, then they need to discontinue use because continued use could lead to the development of drug resistance, because we know that PrEP only involves the use of 2 antiretroviral drugs, and we know that treatment needs to include 3 or more antiretroviral drugs to suppress virus. PrEP doesn't protect against other STIs, so someone needs to be tested for STIs on a regular basis while they're taking PrEP. A person also needs to be monitored for side effects and toxicity, and I think PrEP use also provides an opportunity to engage people in not just support for adherence, which is important to maximize PrEP effectiveness, but also to link them to other services to address factors that may be increasing the risk of transmission. And while PrEP right now is synonymous with the use of a daily pill containing tenofovir and emtricitabine, there has recently been some interesting research that's come out around the intermittent use of Truvada from the PrEP study, and I'll touch briefly upon that. So let's just go through the science about what we know about how well daily Truvada works and how safe it is. So there's been a few different studies that have come out. The first, I believe, in 2010 or 2011, and that was the PrEP study. The PrEP study enrolled gay men and other men who have sex with men, as well as transgender women who have sex with men. It looked at daily Truvada, and the overall risk reduction in the study was 44%. So the rate of HIV infection was 44% lower among those who were assigned to take daily Truvada compared to those who were assigned to take a placebo. So these are the studies I'll be looking at here are randomized placebo-controlled trials. The next 2 studies that came out showed that PrEP works for heterosexual men and women. The Partners PrEP study, which you can see there, also looked at daily tenofovir alone, so that's branded as Viriad. So Partners PrEP study showed that not only daily Truvada works, but also daily tenofovir works. Following that were the FemPrEP and Voice studies, and interestingly, these were done among heterosexual women, but actually found that daily Truvada did not reduce the risk of HIV transmission, which was sort of contradictory to what we had learned from the Partners PrEP and TDF2 studies, which showed that it did work for heterosexual women. And then there was the Bangkok tenofovir study, which enrolled people who use injection drugs and found that daily tenofovir alone reduced the risk of HIV infection for this group. So you can see here that taken together, these studies show that PrEP works, and it works through different routes of HIV transmission, anal, vaginal, and also intravenous drug use. We can see that the sort of range of effectiveness levels varies widely from 0 to up to 75%. And the general consensus was among experts that the reason for this wide range in effectiveness levels is due to varying levels of adherence among study participants. However, when the study investigators actually asked participants how often they were taking the pill, over 90% said they were taking the pill every day, but when they actually looked at drug levels in the blood among those who were assigned to take PrEP, in some studies, very few actually had drug levels in the blood. So it seemed that many people in these studies were not taking the pill daily. So this is the same studies that were on the previous slide, but I've arranged them based on how the overall risk reduction found in the studies. So Partners PrEP had the highest overall level of risk reduction, so I put it at the top. And as I mentioned, the study investigators looked at a small group of people who were in the PrEP arm of the study and looked at the proportion that had drug levels in their blood. And I put that here. And so we can see that studies that had a higher overall HIV risk reduction, it seemed that more participants were adhering more consistently as determined by drug levels in the blood. So we can see here that so in the IPREC study, there was an overall risk reduction of 44%, but when you looked at drug levels in the blood among those who were meant to be taking PrEP daily, only about half actually had PrEP drugs in their blood. So it seems that adherence is very closely related to PrEP effectiveness, and it seems that varying levels of adherence were responsible for that very wide range in PrEP efficacy. And in those where there was no risk reduction, it seems that adherence was very low. Less than 30% actually had drug in their blood. But what the study investigators actually did is that they performed additional analyses that limited their effectiveness analysis just to those who were taking PrEP consistently as determined by drug in their blood. And what they found is that the risk reduction among those who had drug in their blood was much higher compared to the overall risk reduction. So it seems that PrEP, when taken consistently and correctly, can reduce the risk of HIV transmission by 90% or more. So how safe is daily oral PrEP? In these studies, PrEP did increase the risk of some side effects, including diarrhea, nausea, headache, fatigue, and dizziness. These did tend to be mild. They also tended to be infrequent, so only affect about 1 to 10% of participants. And they also tended to disappear after about 1 to 2 months of use. So it seems that it takes a little bit of time for the body to get used to these new drugs, and then side effects tend to decrease. In these studies, there were some more concerning sort of side effects or toxicities. So some people did experience small decreases in kidney and liver health and also bone mineral density. These didn't seem to be associated with any clinical sort of implications. So liver and kidney health weren't associated with kidney or liver failure, and decreases in bone mineral density weren't associated with bone fracture. But a lot of these studies were relatively short, so followed people for an average of 1 to 2 years. So the long-term sort of clinical implications of these toxicities are a little less clear. Drug resistance was generally rare. So as I mentioned, if someone's taking PrEP and they're HIV infected but don't know it and continue to take PrEP, their HIV could develop drug resistance, and this could impact their future treatment options. But it seemed that among those who started PrEP when they're HIV negative and later became infected, not many, very few actually developed drug resistance. It seemed there was a very high risk of drug resistance among those who started PrEP when they're already HIV positive. So these were people who were enrolled in these studies and their infection was missed because they hadn't yet developed antibodies. So they're in the acute HIV infection stage, and they were enrolled into the study when they're in that window period. So it seems likely that the high level of virus during the acute HIV infection stage may facilitate the development of drug resistance. So it really emphasizes the importance of ruling out HIV infection prior to initiating PrEP. And in these studies, there's no evidence of risk compensation. So by risk compensation, I mean risk compensation refers to the concept where people using PrEP may increase their risk behaviors as a result of their PrEP use. And in these studies, we didn't see any increases in risk behavior. It's important to note that randomized controlled settings are very different than real life settings. So in these studies, people didn't know whether the pill they were taking was a placebo or PrEP. So that may influence things like increases in risk behavior and also adherence. So we know PrEP is generally safe and it's effective when taken consistently. So I just want to look at what's happened to sort of move PrEP into practice in Canada and elsewhere. And there's a few things I think are relevant when we talk about implementing PrEP. The first are guidelines. The second is regulatory approval, then off-label prescriptions, insurance coverage, because the cost of Truvada is high, about $1,000 a month, and then demonstration projects and open-label extensions of randomized controlled trials. So these are sort of studies to sort of look at real-life use of PrEP outside of randomized controlled trials. So in terms of PrEP guidelines, there have been some guidelines produced by national and international health authorities. So the Center for Disease Control in the United States has released clinical practice guidelines for healthcare providers, and these are detailed guidelines for how to clinical service providers in how to prescribe PrEP. So what tests need to be done before initiating PrEP, and what follow-up tests need to be done with someone who's on PrEP. The World Health Organization has also developed guidelines, but they're not clinical practice guidelines. They're more practice guidelines for people who are working in HIV programming. In Canada, we have no national guidelines as of yet, but we do have, Quebec has developed some clinical practice guidelines. And the CDC and WHO guidelines both generally recommend that PrEP be offered to people at high risk of HIV infection, and they sort of define high risk in different ways. So in terms of regulatory approval, Truvada is approved for the treatment of HIV in most countries worldwide. However, the Food and Drug Administration in the United States is the only country to approve Truvada for the prevention of HIV, so for use as PrEP. As of yet, Truvada has not been approved for use as PrEP by Health Canada. But since, for regulatory approval to happen, the company that produces Truvada, Gilead, needs to actually apply for approval to Health Canada, and as of yet, that has not happened. So the regulatory approval process hasn't really gotten started here. But even in the absence of regulatory approval, because off-label prescriptions are legal here, PrEP is available in Canada. So off-label prescriptions refer to the prescription of an approved drug for an unapproved use. So in this case, Truvada has been approved for the treatment of HIV. Therefore, it can be approved for the prevention of HIV, even though it's an unapproved use, because there is that evidence from those studies that PrEP does work for, Truvada does work for PrEP. So this off-label prescriptions are common for some types of drugs, as many of you know here, and it's legal. So in Canada, someone can access PrEP as long as they can find a healthcare provider who is willing to prescribe Truvada off-label, and they can find some way of covering the cost. Of course, there's many barriers to both of those sort of steps. Many people do not have access to a healthcare provider. Their healthcare provider may not be willing to prescribe it. Many people cannot afford the cost of PrEP, particularly out of pocket. It seems that some private health insurance companies are willing to cover the cost in Canada. But as we know, many people also don't have private health insurance. So I like to say that PrEP is available in Canada, but it's not necessarily accessible, and there are definitely barriers to access. So there's still several sort of implementation questions that remain unanswered around PrEP, particularly in Canada. So one is, how do I identify optimal PrEP candidates in our practice? In the guidelines, they say that recommend that PrEP be offered to people at high risk, but how do you define high risk? It's a very difficult thing to define, and it's becoming more difficult as our sort of knowledge of what's risky and what isn't changes. We don't really know how many people and who want to use PrEP. So for example, if we made it more widely available in Canada, who would be the people who would come forward to use it? Would they be high-risk individuals, or would they be sort of the low-risk, high-anxiety? How is PrEP used in real-world settings? In the randomized controlled trials, we saw that adherence was a challenge for many people, and risk behavior did not increase. But as I mentioned, randomized controlled settings are very different than real-life settings, so we need some more research on how PrEP is used outside of the randomized controlled setting. What are the best ways to support adherence and risk reduction? So as I mentioned, PrEP really does provide the opportunity to engage people that perhaps we otherwise wouldn't be engaging, and to support them with HIV risk reduction. What impact does using PrEP have on overall health and well-being? Some of you may be aware of a Huffington Post article that was published that sort of denounced PrEP users as Truvada whores. And I think that's an example of how PrEP use could lead to PrEP-related stigma and potentially have a negative impact on people's mental health. But there's also some research coming out that among PrEP users showing that PrEP use does actually have quite a positive impact on someone's mental health, particularly around reducing some of the anxiety related to the risk of HIV infection and so-called risky sexual behaviors. And another question is, what is the best setting for PrEP delivery? Is it out of a STD clinic? Is it out of a community-based organization? And so on. And so to answer some of these implementation questions, there are a number of demonstration projects and open label extensions currently ongoing. So these studies are providing PrEP to people, and they're doing so in what is called an open label format. So they're giving the pill to people, and they're telling them that it is PrEP and that it works. And so that's very different than sort of the randomized controlled setting where someone doesn't know whether the pill they're getting works. So there's a whole bunch going on. They're mostly in the United States and sub-Saharan Africa, but there is one currently ongoing in Toronto, which is being led by Dr. Dale Tan out of St. Michael's Hospital. And evidence is beginning to emerge from some of these demonstration projects. So we've seen one come from the iPrex open label extension, which showed that PrEP uptake was high outside of a randomized controlled setting, and that it worked. Although in the iPrex OLE, many people also had trouble adhering in that study. But more recently at CROI in Seattle, which was this week, some information came out from the PROUD demonstration project, which is a demonstration project among gay men and other men who have sex with men in the UK. And they actually found that adherence was very high, which was good news. So moving forward, I think there's many things we can be doing to integrate PrEP into our work. I think there's a real need to improve awareness and knowledge about PrEP, and not just among those who are at risk, but also among service providers, because I think there's several different types of service providers that are involved in PrEP implementation, and I think awareness is generally low. Support PrEP-related decisions, so we know that PrEP isn't for everyone, and it's important that we sort of work with a client or patient around helping them decide whether or not PrEP is right for them. Facilitate access to PrEP, so that may be around linking someone who is interested in PrEP to a healthcare provider who's willing to prescribe, or helping someone find insurance coverage. Support adherence and risk reduction for people who are actually using PrEP, and also sort of push for demonstration projects, guidelines, and regulatory approval. Even though we don't have regulatory approval in Canada, we can prescribe it here, but I think regulatory approval is an important step for sort of leading to broader awareness in Canada, and also broader sort of insurance coverage. And I've included a couple of things out of Canada here on the side. So at the top right there is a pamphlet produced by the AIDS Committee of Toronto to help improve awareness among people in Toronto around PrEP. And at the bottom there is an advert from a gay magazine in Montreal. There's a clinic in Montreal called Clinique L'Actuelle that's actually actively promoting PrEP in the gay community. And I think the United States right now is much further ahead than most countries in terms of PrEP uptake. There's regulatory approval there. There's local and national guidelines, a whole bunch of awareness campaigns and PrEP resources. It seems that most private health insurance companies in the States are willing to cover the cost of PrEP, and Gilead has actually set up a financial assistance program for those with low income. There's actually a national PrEP telephone line for clinicians there. So if a clinician doesn't know about PrEP or doesn't know how to provide it, they can actually call this national helpline to get support. In San Francisco, they have an interesting community navigator program, which actually helps clients or patients find a healthcare provider who's willing to prescribe it and actually find a way of covering the cost. So navigate the sort of insurance coverage process. And in Seattle, there's actually a publicly available PrEP providers list. So there's actually a publicly available list of providers who are willing to prescribe PrEP. So someone who wants to start it can find a provider who's willing to prescribe. So as I said, right now, PrEP is currently synonymous with the daily use of Truvada, but that may not always be the case. And in fact, Ipergay, which is a study that had a couple sites in Montreal or in Quebec, and also sites in France, recently found that intermittent use of Truvada is effective. So pills taken before and after sex actually did reduce the risk. But I think the regimen was something like 2 pills before and then 2 pills on the 2 days after sex or something like that. So if someone was having sex basically once a week, they were essentially almost taking daily Truvada. So I think what the study showed us is that, perhaps near perfect adherence isn't necessary to gain some protection, but it'll be interesting to see how much this actually influences practice or guidelines. There's also the potential for the use of other pills other than Truvada. They're also looking at rectal and vaginal gels that contain antiretroviral drugs. And there's also some research going on around long-lasting injectables and intravaginal rings. So these would be options that would only need to be used like once a month or once every 3 months, and that would sort of decrease the need for daily adherence, which seems to be challenging for some individuals. So thanks a lot. I know I went pretty quickly there, but got through it on time.